Orchard. Dr. Orchard is the medical director of the MPS-related transplantation program and is professor of pediatrics at the University of Minnesota. He is interested in the use of hematopoietic stem cell transplantation and other cell therapies such as gene therapy to improve outcomes as well as increasing the effectiveness of transplantation. Welcome, Dr. Orchard.
Thanks very much. I haven't done anything yet, so thanks for that. I appreciate that. And it's great. It's a huge turnout here. I'm really kind of, amazed at how many people who are here today. And we'll be around as was mentioned for a little while. So if there's questions after this that we may not be able to get a chance to answer during the presentation itself, please seek me out. I'm pretty easy to find. So a few things. Let's see. How do I make this work? Yep. There we go. Okay, so I have some disclosures as well. Primarily, we work with companies in terms of clinical trials, so and we're involved in a number of those. A few things I wanted to touch on today. So primarily, we're going to talk about treatments for the MPS disorders. I'm going to talk a little bit about transplant, as you might imagine, how people get to transplant, what the issues are there, what the benefits of transplant are, and what the limitations of transplant are, and then where we might be going moving forward. All right, I'll figure this out here. Okay, just to demonstrate things, this is what a biopsy of a normal liver looks like, and you can see all the pink tissue there. It's healthy looking, and this is what liver looks like from a patient that has an MPS disorder. So this foamy appearing material that's there is this buildup of the substrate or glycosaminoglycans or storage material. So this is what happens throughout the body, and for many of the diseases, it localizes to one place or another, but for diseases like Hurler, it's throughout the body, really. So this is what we're trying to alleviate, is the buildup of this storage material. So there's several different strategies, and this isn't exclusive in terms of what I'm going to talk about today, but enzyme therapy, everybody here is aware of. I'm just going to touch on that very briefly. Then we're going to talk about transplantation and then get into gene therapy down the road. So ERT to start. So just a couple things I want to mention about enzyme therapy. Again, people here are well experienced in how enzyme therapy works. You have to give it essentially every week throughout the life of the patient. So it's a burden on the family to have to do this. It's very expensive, and it doesn't work for central nervous system disease. So the brain is really not effectively treated with enzyme replacement therapy, which is one of the big limitations. One of the other things I wanted to point out on this slide, so some of the enzymes that became available, well, the earliest were in 2003. So you've got 16 years worth of experience with using enzyme therapy, whereas transplant really got started back in the 80s. And we'll go through that here in just a minute. So I want to focus the next part of the talk on transplant. So this was the report of the first transplant that was done for an MPS disorder. This was a little boy with Hurler. It was transplanted in Bristol in the UK, and mom was the donor. And there was a decrease in the glycosaminoglycans, and the activity level picked up, and the boy's liver and spleen got better. So this really opened the floodgates for using transplantation for the lysosomal disorders. I want to talk for just briefly about the transplant process, or at least getting to transplant. So if we identify somebody that needs to get transplanted on the bone marrow transplant service, then the key questions that you ask up front is, what's the donor situation going to be? So for full brothers and sisters, there's a 1 in 4 chance that they will be an HLA match, and that's what we're looking to achieve. The better match you've got, the easier the transplant ends up being. So we look at the brothers and sisters to start. Generally speaking, the brothers and sisters are older, so there's a good chance that they don't have the same disease. Obviously, you want to eliminate that as a possibility. But for the recessive disorders, so Hunter's a bit different, but the rest of them, the brothers and sisters could well be carriers, even if they appear normal. And if they're carriers, they're going to have less enzyme than somebody who's not a carrier, and it's not optimal in terms of doing a transplant. So, given the opportunity to use a donor that's not a carrier, we would opt to do that. So for most of our families that could potentially go to transplant and benefit from transplant, we have to look outside the family. So if we get the HLA typing on the child that's going to go to transplant, we can search the databases to find potential donors. So there's two different groups that we look at primarily. There's the unrelated donors. So the unrelated donors are people that are adults that have had their HLA typing done. It's stored in a database at the National Marrow Donor Program, or Be the Match is the other name for that group. And there's about 20 million people that have been part of that registry. The other source of blood stem cells is cord blood. So when a baby's born, there's a fair number of blood stem cells in the placenta. Those have been stored now over a period of the last couple of decades, so there's hundreds of thousands of placental blood units or cord blood units that are frozen down that we can search as well. So DNA has been extracted from a small amount of that cord blood, and that's available too, so we can search kind of simultaneously for unrelated donors and for cord bloods. Whoops, going the wrong direction. So this is the process primarily. Again, it takes about 10 days to get the HLA typing on someone who needs to go to transplant. The electronic search through the National Marrow Donor Program is free and quick. We can turn it around in a couple of hours and give us an idea of who's out there, what's out there in terms of potential donors. The next piece, though, is if there's a donor, and the donors could be anywhere throughout the world, we would call the National Marrow Donor Program, because we work through them. They contact the center that's closest to the potential donor. They have the donor come in and give us a sample of blood shipped to us, and we would confirm that that donor looks like they're well matched. So again, that process takes about 10 days or so from the time the donor comes in, and that actually costs money. So it's a couple $1,000s to do the HLA typing, and that ends up going on the insurance of whoever's going to get transplanted. For the cord bloods, essentially the same process. We go to the cord blood bank and say we're interested in cord X. They send us a little bit of DNA from that cord, and we would confirm the typing. With the cord bloods then, though, you're done. So from that time where we confirm that the cord blood is well matched, and usually we do enzyme testing just to make sure that there's enzyme present in the cord blood. But after that, that's all we need to do. For the unrelated donors, they have to come in and have an evaluation done, so they have a physical exam, they have blood testing done, they have chest x-ray. We want to make sure that those people are healthy, both from the standpoint as we don't want to give whoever's going to get transplanted something infectious, for instance, and we want to make sure that the unrelated donors are healthy enough that if they go through the operative procedure to harvest marrow, that we're not going to hurt them or put them at risk, because they're essentially doing this out of the goodness of their heart. So because there's extra steps with the unrelated donors, it takes longer. And at least in our hands, probably, assuming you've got good choices both directions, we would generally go with the cord blood because it's quicker and we have more control over the process. So about 75% of the kids that we transplant for Hurler, for instance, are cord blood transplants. So I want to talk a little bit about the role of transplant for the various MPS disorders. So MPS 1 is really the prototype. So we divide this into two groups. So there's the severe disease, the Hurler kids, and then there's the attenuated patients. So there's different therapy or recommendations in terms of therapy based on the severity of the disease. So the kids with Hurler tend to have neurocognitive issues. And again, to try to treat the brain, transplant is used for those kids. For the kids that have attenuated disease, that you wouldn't anticipate are going to lose ground from a neurocognitive standpoint, or at least not nearly so much, those patients essentially go on enzyme. So at least at this point in the US, that's the big fork in the road. If you have severe disease, you get transplanted. If you don't, you go on enzyme. There may be some exceptions to that, but that's generally what happens. Hunter is a bit more difficult. So Transplant seems to work better for Hurler in terms of preserving neurocognitive function than it does for Hunter, for reasons that we don't understand very well. There's certainly data that if you can pick up the Hunter patients that you know are going to have neurocognitive problems and you intervene with transplant very early, they look much different than a brother who hasn't been previously treated with transplant later. So it certainly helps preserve some cognitive function, but it does not stop progression totally. So, being able to identify which boys are at risk for neurocognitive deterioration, it can be difficult too. So we don't have a great way at the time of diagnosis to be able to know that. So Hunter is more difficult. There is some groups that are doing newborn screening for Hunter, but it's only a few states in the country at this point. In terms of Sanfilippo, so Sanfilippo is primarily just a neurocognitive disease, and transplant, unfortunately, has not worked very well for that. And again, why transplant works quite well for MPS 1, but not so much for MPS 2, and not hardly at all for MPS 3 is not clear. The cell sources are the same, the transplant procedures are the same. Presumptively, you just need to get more donor cells into the brain to be able to stop disease progression, and what we're currently doing with our standard transplants are not sufficient for the MPS 3 kids, so we haven't transplanted a Sanfilippo kid for many years. In terms of Morquio, so there's enzyme available for Morquio, and because they, again, don't have neurocognitive problems like the Hurler kids do, we generally would not transplant a Morquio patient, and we haven't done that for years. One of the issues, and I kind of skipped over this in terms of the Hunter patients too, but in Japan, they've been doing more transplants for some of these other disorders. So Hunter's quite common in Japan, or more common, and they have been doing transplants for Hunter in Japan and comparing, there was a paper several years ago comparing the outcomes of the kids that were just treated with enzyme and the kids that were treated with transplant. And there was some sense that there was better outcomes, not just the neurocognitive side, but just in general with the kids that were treated with transplant. The Japanese have also transplanted some of the Morquio patients, and there's some sense that that may be true as well. But due to the increased risk of transplantation, as opposed to just giving enzyme, it's not a standard thing to do in the US, at least to treat the Morquio patients with transplant. In terms of MPS 6, so the Meritola patients tended to do quite well with transplant before enzyme was available, and we transplanted, it's a rare disease certainly, but we transplanted a number of those patients that have had decent outcomes. But again, the neurocognitive piece is not a big part of MPS 6, and so as enzyme became available, almost all those patients are going on to to stay on enzyme. So we don't see those patients very much. The SLY patients, MPS 7, is very, very rare disease. There's very little information in terms of transplantation for those patients. And there's alternative therapy now too. So that is not something that we have much experience in just because it just doesn't come up very much. The ICEL patients have not done well with transplant. And just in the last few years, we put together the international consensus of how these patients have done. And they have done sufficiently poorly that, generally speaking, we would not consider transplanting an ICEL patient. Unfortunately, it just doesn't work well enough. So I want to focus a bit more on the MPS 1 patients because that's where we have most of the data. So there's over 50 lysosomal storage diseases that have been identified. Hurler is just one of those, or MPS 1 is just one of those. The incidence is about 1 in 100,000. There's about 4 million kids born in the US a year, so it's 40 kids that would have MPS 1, according to those numbers. And this, again, is kind of the pathway. So down the left side, if you identify a patient, they're relatively young, look like they have severe disease, most places will put the kids on enzyme while they're getting the transplant set up. That's not done universally, but most of the institutions that transplant the Hurler kids would do that. And then they would go on to transplant, assuming that the condition of the patient is sufficient to take them to transplant and you had a good donor. For the kids that are older, presumptively either have attenuated disease or they're more severely affected with Hurler because they're older, those patients may just go on enzyme therapy. And then there's a bit of a caveat that you may head either direction for either group, depending on the circumstances. So in terms of outcomes, so I can't go through everything. I mean, Liz talked about the cardiac issues, and Linda talked about some of the endocrine issues, and Clayne the orthopedic issues. So we're not going to go through all those things that the experts actually have already talked about, but I want to hit on some of the highlights here just to make a few points. In terms of survival, this was a study that was done looking at the relative outcomes with the two treatments that are available. So this is, again, focused on the Hurler patients. The curve here that goes down most steeply are the untreated patients. So this is historical data. Most of the kids with Hurler die by the time they're 10 if you don't have any therapy. When enzyme became available, there was a number of families that said, we don't want to go to transplant, now we've got something else. We recognize that transplant's a really difficult, risky thing to do, so we're just going to put our kids on enzyme. So that's the middle curve there. And then the survival with transplant is the upper curve. So you can get a sense from this that survival is better with transplant than with just going on enzyme, accepting that there's significant risks of transplant, especially in the early phases. The point of this is just to say that hopefully one would expect over time outcomes with transplant have gotten better. So this is from a multi-institutional group that have put all their data together to publish about the Hurler kids. So over time, survival has gotten better. And at this point, generally speaking, we would say it's about 85% in terms of transplanting the Hurler kids now. The point of this is, so this is the same data set as we were talking about before. So the median age of transplant in that group was 16.7 months, so they just compare the younger kids versus the older kids in terms of transplant, and the younger kids are more likely to do well with transplant in terms of overall survival. So younger is better. One of the things that actually Liz had mentioned a little bit earlier, and this is actually data that she and some of her fellows pulled together. So if a family comes to me and says, so we're going to do transplant, assuming transplant goes well, how long is Mary or Johnny going to live? We can't really say. I mean, most of the kids that are transplanted are 1 or 2 at the time of their transplant. We've only been doing this since the 80s. So, what's their life expectancy beyond 20 years or so? It's difficult to know. One of the things that was key from this, though, is that there's a fall off early, and that's the peri-transplant complications and mortality. But the curve isn't flat after that. There are still patients that are dying 10, 15, 20 years out after transplant. And exactly what they're dying from is not so clear, because they may die at home and we may never really find out exactly what happened. But this is important because we need to better understand what our limitations are in terms of having people survive longer. So this is going to require more information and more study to help us better understand what our limitations are. In terms of neurologic disease, so this is essentially the deterioration of the cognitive function in the Hurler kids if you don't do anything. So this was published many years ago. The kids that are a few months old seem to be absolutely fine, and as they get older, though, they continuously lose ground. So this is one of the things we want to target with our therapies. If you look at the outcomes with transplant, and again, this was a large multi-institutional study that pulled together all this data, but if you look over on the left side, if you assume that a normal IQ is greater than 85, prior to transplant, 57% of the kids were in that group. But if you look after transplant, there's only 27% that were in that group. So these kids are continuously losing skills, and they tend to stabilize and plateau after transplant, but they lose ground going through that transplant process. And so this is another issue and limitation that we need to be able to address. The boys don't tend to do as well as girls do. If you have a low IQ coming into transplant, your outcomes aren't as good. If you're older at transplant, your outcomes aren't as good. We used to use total body radiation, which is what TBI is. We don't do that anymore, but the kids that were treated with TBI did not do as well either. So in terms of the orthopedic outcomes, and this is actually Linda's data, so looking at the growth of the kids post-transplant, and over time the kids tend to fall off the curves. So again, they get some benefit from transplant in terms of the orthopedic-related pieces, but we're not fixing that with transplant. And this is a curve looking at the various surgeries that the kids may need after transplant as well. So carpal tunnel is prominent, but a lot of the kids have back surgeries, knee surgeries, and hip surgeries that Clayton was talking about. Cord compression is also an issue as well. So again, these kids are not cured in terms of their skeletal disease. So if you break down that a little bit and you look at, for instance, the kids that need cord blood, or the kids that are post-transplant, you look at whether they need carpal tunnel surgery, the kids that have higher enzyme levels are less likely to need the carpal tunnel surgery, which is important to understand because it seems like there's a dose effect in terms of decreasing the risk of the carpal tunnel surgery. Also, if you break it down and look at the ages, if you do the transplants earlier, that may be protective as well. So both enzyme levels and age are important in terms of outcome. So just to summarize what we've talked about thus far, transplant has gotten better in terms of safety, but it's not adequate as therapy. So the orthopedic issues, the neurologic issues, endocrinology issues, the cardiac issues, all these things are still things that we need to be aware of, and we need to do things better than what we've been doing. So more enzyme may be better, earlier transplants may be better, so those are things that we need to explore. So what's on the horizon from here? So newborn screening is certainly becoming an issue. So I think this is the most recent data. So there's 20 states that are doing newborn screening for MPS 1 now. So we'll have the opportunity to identify these kids essentially at birth so they can start enzyme quicker. The Hurler kids would likely go to transplant within a few months. The few kids that we picked up with newborn screening, generally at 3 or 4 months of age, have gone on to get transplanted now. But that data, how much difference that's going to make is going to be important, and that's something we need to look at. There aren't that many kids that have been transplanted that early, so that data's got to mature a bit. In terms of making transplant better, we're doing a study with a group called Magenta, or a company called Magenta. Magenta developed a way of expanding stem cells. So if for instance, you're doing a transplant with cord blood, there's only so many blood stem cells in that unit of cord blood, but they've developed a way to help increase the number of stem cells. So as we transplant the kids, we have a larger cell dose to use. And the more cells that you give, generally speaking, the better the kids do. So we're exploring this now as an option. So we have a trial open that is looking at using larger numbers of cord blood stem cells to see if we can make a difference. And then gene therapy. And I just want to there's a number of different ways to do this, but I just want to hit some of the highlights here. So one of the studies, there's a study currently ongoing in Milan looking at a lentiviral approach for gene therapy. So essentially there's two different ways to do, there's a lot of ways to do gene therapy, but you can kind of break it down into taking cells out, engineering them to make enzyme, and then putting them back in. So that's what we call ex vivo. The other would be actually treating the patients with injecting viruses, for instance, into the patient themselves. So this approach is the former. So kids that are going to go to transplant, they have their stem cells removed by a process called apheresis. It's a machine that spins the cells out essentially, and you can kind of collect them. Then they go on to be infected with a virus, a lentiviral vector that contains that gene, and it allows the cells to make a lot more enzyme than they would otherwise make. So then they have this corrected population of blood stem cells. The kids still need to go through chemotherapy because you have to get rid of the blood stem cells that aren't making enzymes so you can put the corrected ones back in. So those are reinfused. So I think there's 6 kids, maybe 7 kids have been treated in Milan using this approach, and the data looks quite encouraging. We're interested in using a different approach. This is a company called Immusoft has developed Sleeping Beauty transposon system. So this is a non-viral approach. Essentially just takes DNA and gets the DNA into the cells. Here they're targeting B cells instead of the blood stem cells. But essentially the process is somewhat similar. Kids have their B cells, and those are the cells that make antibody. They can make a ton of protein. Those cells are pulled out by apheresis. This is a non-viral study, so essentially they have the DNA and they pass an electric current across the cells. It's called electroporation. The DNA makes its way into the cells from that. And then you have these cells again that are corrected and they're reinfused into the patient. So the way this protocol is going to be designed, there is no chemotherapy, which may be an advantage if it works, but the trial hasn't begun yet. So I'm hoping in the next few months this will get off the ground. There's also different types of viruses, including adeno-associated virus. So this is one of the studies where the virus is injected right into the patient. This is primarily to help treat the central nervous system, the AAV approach that's set up like this. So essentially you take this virus, it's injected into the cisterna magna, which is the back part of the head. That's where kind of a pool of the spinal fluid is. The idea is then this virus can circulate from the spinal fluid around the brain and transduce the cells of the brain, and then have the brain cells make their own source of enzyme. So this may well have some utility. One of the questions there, though, is whether or not sufficient enzyme is going to get out of it. So this is just targeting the brain, really. So how much of that enzyme is then going to make its way out of the brain and treat the rest of the patient? So, because if you may have to use enzyme or even potentially transplant or something to help treat the rest of the patient. So we'll know more in the next few years as these studies mature. So I'm going to stop there, and I don't know how we're doing for time, but hopefully there's some time for questions. Or are we going to do a panel a little later? Okay, very good.